I'm really happy to share with you the current insight in diagnosis and viral monitoring of SARS-CoV-2 infections, and also share some of my own experience. These are my disclosures. And if we talk about diagnosis, actually we need to start with the golden standard, and that is viral culture. And it can only be done in a P3 facility because of the risk of the virus. And it can be done on ape lines, viral cell lines. And the problem with these cell lines is that they actually give a rapid viral adaptation to the virus. So people are working now on using different cell lines, for instance, cancer cell lines, but they don't have a natural cell receptor for the virus to enter, so that needs to be engineered. But it's not that easy. It's also not for clinical diagnosis. But why is it here as the golden standard? Well, because it's really the test to assess viability of the virus, and that can be really important. You have to realize you cannot just culture any sample. You will need a PCR value below 29 to have good success. Above that, it's more complicated. And this is, of course, not a standard procedure. So what we do in regular clinical practice is molecular detection of SARS-CoV-2 genome. And the SARS-CoV-2 RNA is a really large RNA. It's a large coronavirus, and it has 12 potential gene products. And of these encoding genes, often combinations are used for molecular diagnostic asparagines. And in theory, this could actually potentially impact the detection if mutations would occur in one of these targets. However, current variants of interest or variants of concern are actually adequately detected in most currently used assays. So molecular testing for SARS-CoV-2 is regularly done by the classical RT-PCR. RNA is then described into DNA, which is amplified by PCR and subsequently detected. However, more and more, we also see a new kind of molecular testing, which is isothermal recombinase polymerase amplification, or RPA. And this is a modification of PCR, and it uses different enzymes in a way that we don't really need the cycles with different temperature, and it allows amplification in a more easy and simple way. Now going back to PCR, PCR is complex. It requires 3 reagent kits, one for the extraction of RNA, one of making the cDNA, and another one for amplification and detection of the nucleic acids. However, it's very specific, and it can be semi-quantitative, which is or quantitative, depending whether you have the stock and can count your viral load. What we do have to realize is that there's a lot of discussion about the sensitivity of the SARS-CoV-2 PCR. For a virologist, it was a little bit strange because we know that PCR is such a highly sensitive technique. And if you look at those early publications really discussing the sensitivity of the assays, you actually see there's often sampling very early after exposure, just in the incubation period, or sampling late in disease. Various ways of sampling collections. We had to learn what the best way was to actually collect the RNA, but also the preservation of samples. RNA samples should be actually collected in the correct viral transport medium. And then in the beginning, there were technical limitations of the early RT-PCR, which may not have had the best targets as the commercial assays that we use today have. What you can see here in the picture is actually the amplification cycles of the PCR. And even if you don't have qPCR, so a quantitative PCR, you can use the amount of cycles that you need to detect the virus as a kind of semi-quantitative measurement. And that means that if you have a high number of cycles, you have a low viral load. If you only need a few cycles to detect the virus, there's a high viral load. This picture really gives viral shedding during the COVID infection, which actually starts before the symptoms start, and then maximizes and then gradually decreases, but not always tips the bottom of the detection curve. It's best detected in nasopharynx swabs, but there are different materials that can be used to sample. If we look at viremia in the blood, prevalence of RNA ranges from 1 to 8%, and we do know that's associated with increased clinical severity. So people that you do find viremia are often very ill. There have been some large studies with the mean duration of SARS-CoV-2 RNA shedding, which is always a bit difficulty because you need to know when exposure was to really know what the time of shedding is. But you can see that actually there is a difference in the upper respiratory tract compared to the lower respiratory tract, but still is quite similar. This is a really nice paper from Christian Drosten's group, which they looked at viral shedding in mild disease in rat and advanced disease. What you actually can see is that there is a difference because many people with mild disease were measured earlier, and people who were actually measured at time of advanced disease, the time that they were admitted to the hospital, were already ill for over a week, so they have lower viral loads. So actually the difference can be explained by sampling later in the course of infection. Very important to realize when you make these comparisons. What about the persistence of viral RNA? We have to realize that RT-PCR does not evaluate the infectious capacity of the detected RNA. So we don't have to really sample viable virus. And in some people, you can recover RNA over 100 days after complete clinical recovery. That's a long time for an RNA virus to stick around. Of course, we don't know even if it's intact virus because we only target with our PCR parts of the RNA. It seems more frequent with mild disease from a clinical perspective, which may indicate that the immune response is unable to promote RNA clearance if people don't have such a strong immune response. However, in vitro research did not confirm that. And actually what was seen is that people who have this prolonged shedding at least have a higher CD8 T cell response, suggesting that the low level viral persistence results in an ongoing immune stimulation. And in our clinic, to monitor this, we decided that a CT value of 35, we call that it's a borderline positive PCR, and a CT value above 32, between 32 and 35, we call weak positive. And we use these terms to get people out of isolation and to get hospital employees back to work, and not just positive PCR results. So we give a little bit of extra nuance. There's also another molecular test which is quite interesting, which is the LAMP. And this is also a test based on isothermal amplification, only it's loop mediated, and I'll show you in a minute. What is really interesting in this test is that you don't need also the cycles with different temperature. That means that's a much quicker test than the PCR. And here you can see it. What actually happens is that you use much more primers, and the primers actually make kind of a loop. And here you can see that. And these loops enables very easy amplification. It goes very rapid. And that turns out in a rapid assay. The assay equals PCR in sensitivity and specificity, is quick. However, it's not a completely laboratory setup that's fully automated with ready-to-go kit. So it still needs some hand-on work. But a low amount of people can process a lot of samples. Here we go to the point-of-care molecular diagnostic test. These are actually the tests that you could also perform outside a complex laboratory setting. And you still need knowledge and a good and clean way of working, but it's not that complex. And it is because it is working mainly with cartridges. The GeneXpert is a very sensitive variant. There's a dual target for the nucleocapsid and the envelope genes. And then you have the ID now, which only has a single target, the RBRP gene. It's reportedly a little bit less sensitive, but actually that's only true for the higher CT values. And I think in clinical practice, it's a very favorable test. Then you have the Simplexa, which detects also dual targets, ORF1 and spike, which of course is a bit complex because spike is an area which may more easily mutate, and therefore you could have issues. Luckily, it's a dual target assay. And then you also have various multiplex assays, for instance, the COBAS assay or the EPLEX. And these assays do not only detect SARS-CoV-2, but also other viruses. So what do we use in our hospital? Well, for people who have signs of respiratory infection, and it could be anything, we do an EPLEX. This test is a multi-target, many viruses are detected. It takes about 2 hours. So it's quick, but not that quick. If we have a suspected COVID case, we perform a SARS-CoV-2 ID now, which is ready in half an hour. And if this test is negative and we still have a high the suspicion of the infection, we can use as follow-up the gene expert, which takes an hour and has a dual target. However, in my experience, we have not seen anybody who tested negative in the ID now was positive in the gene expert, only if it was a really high CT value, so actually not a very active viral infection, maybe somebody who had the disease months ago. For our follow-up monitoring of COVID positive patients, we use the C-gene, which is a triple targeted assay, which really gives us insight in viral dynamics over 3 targets. If we are in a bit of a hurry, we can always use the gene expert, which still has dual targets. So quite some assays, and I have to say it's really nice to have different choices for different indications. What about the antigen test? Antigen tests are actually diagnostics that detect viral protein instead of nucleic acid. And they can be performed on nasopharyngeal swabs or a nasal cavity. But nasal cavity is sometimes a little bit less sensitive than the nasopharyngeal swab. Most of them are immunographic assays, and you can see Abbott's example here, but there are also assays who are fluorescence immunographic. And they're very rapid, both of them, and you have multiple assays available with variable sensitivity. We did a validation on the PenBio, so this one, it's a nucleocapsid protein detection, which is nice because the nucleocapsid is really early infection expressed abundantly, secreted abundantly. So that helps with early detection. Well, we compared this test with the PCR, and what you can see is that actually in the symptomatic population, so people who have already complaints of the disease, and we had over 1,000 patients with 134 positive, so about 10% prevalence, we had 100% specificity and a sensitivity of 70%. However, if you only look at really active viral infections, so those with CT value below 32, the sensitivity increases up to 95%. So with this test, you really detect those people that are infectious, but not the prolonged shedding of the RNA. This could be a really nice test that you could use, for instance, at an event. So we also look at the asymptomatic population. Of course, a low group of positive people there. And we saw also high specificity, but the overall sensitivity dropped a little bit. But here again, we looked, what were we missing here? It's actually the early infections. We were not missing, we were missing the ones that were having prolonged shedding. So really the people late in the infection. Again, you know, emphasizing that this test is very much a test to detect people who are infectious. So is this something that you could perform at an event? Well, this is a pop-up laboratory that we built at a conference venue. Here are people samples. And then actually, if you do high numbers of the antigen test, we're talking here about 4,000 samples a day, then it really becomes complex because you have to read them within a specific period, otherwise they can over time look like they are positive if they're not. So we made with people from the HoReCa, people from the dinner parties, a kind of projection, which actually gives a time for a test when it should be read. And also we made with people in the hospital 3D print with a kind of plate that we could put the test in, the negatives in the white and the positives in the red, for confirmatory check by another tech. Quite difficult to perform these tests in high numbers. Very easy if you do a few, but actually very labor intensive compared, for instance, to LAMP, if you want to do this kind of volumes. And there's a new kid on the block, which is the breath analyzer test. It's a test that actually is not really specific measuring the virus. It's looking at the chemical composition of the air that people expire. And the sensitivity ranges between different studies. In the Netherlands, we used the eNose, and the eNose was really well validated in 3 independent cohorts from the test set. And there we saw that we can actually rule out infection in 70 to 75%. In the other people, the other group, the 30 to 25%, they need follow-up testing with PCR to see whether they are positive with SARS-CoV-2. So a high sensitivity, but a lower specificity. And it's also a little bit difficult test that it's very sensitive for airflows or for alcohol, which doesn't really make it a likely test that you could use, for instance, before entering a pub. So it's a quick, low-cost and non-invasive tool, and for excluding COVID-19, but you need follow-up for real detection of the positive ones. Then what about serology, measuring antibodies? Well, a lot of people thought it was interesting because there are more than 200 different serological tests. And these tests are really valuable, but we have to realize they need to be used not for detection of acute infection. They're not suitable for that. They can detect different sources of antibodies, IgA, IgM, IgG, or combinations. And they can also be targeted at different antigens, for instance, nucleocapsid or the spike protein. And on different materials they can be used. You can quickly see it. So what you have an antigen coating, you put your patient serum, if there are antibodies they bind, you wash, and then you detect the antibodies with anti-IgG antibodies, which give a signal, and you can measure that. Very easy, for instance, in ELISA, but also in a flow assay, the same kind of methodology works. And then you have a quick test, a little bit less sensitive than the ELISA that's done in a regular laboratory. So when do these antibodies pop up? Well, really after the initial phase of infection. And you can see that high amounts of people become positive after more than 15 days of infection. And many people, of course, have then already resolved the infection. So in that way, they're really not made it suitable for detecting acute infections. So how long does this antibody response stay on? First, we thought it was relatively short, but actually this also, some of the newer assays also measure neutralizing antibody titers, and especially the spike protein targets. And they can actually be measured pretty long, the response. So what's the sensitivity of these assays? Well, if you look very early, and here you can see the days, day 7 to day 35, and you can see this is all different tests. And what you can see is actually all of them become really sensitive if it takes longer to be before you measure. But in the first week, they're really not very useful. And the specificity, we were a little bit afraid in the beginning that they would give a lot of issues with circulating coronaviruses from the past, but actually most of them are relatively very specific, and some okay. The applicability of serology. When do you use serology? Well, it can be really well used for public health management to measure at the population level who has antibodies and who has not seen the virus yet. For diagnosis of suspected COVID, it's only interested for patients who present really late, and maybe have still long disease, but not active viral replication anymore. Also, it can be interesting in the clinical practice for patients who are not able to clear the virus and still have a high viral load. And then you can see whether those people actually make an immune response. And if they do not, you may decide to give them antibodies or maybe start them remdesivir. So in that perspective, we do use serology also in clinical practice. Then it's kind of interesting that you can, if you have different assays, use them to correlate people who have been exposed to the virus and have cleared the infection and people who actually are vaccinated. The vaccinated give the spike antibody response and but not a nucleocapsid response. And in that way, you can use the assays to differentiate between antibody responses. There's no strict relation, unfortunately, at this time with protection. Although the spike-based assay also measure the total binding antibodies, so they do include neutralizing antibodies. They do have a relation with the plaque reduction assay, which is the gold standard for that. But there's not a clear cut-off that you can say at this level you're protected for reinfection. So in conclusion, molecular tests are the most sensitive and specific. High sensitivity, however, also means prolonged detection, which may not be very useful if you look outside hospital use of testing. So various assays are preferred in different situations. As early diagnosis is essential for patient management, but also for outbreak control, development of rapid, scalable, easy accessible, and high accurate point-of-care assays should be prioritized and further developed. Finally, I would like to acknowledge my colleagues Marije Hofstra, Hendrik Gremmels, and Monique Nijhuis. Thank you.